the post-test. Anyway, so we are going to be talking about statin intolerance and medications to manage LDL cholesterol in patients who can't tolerate statins. Cady Schleeper is a PharmD resident, and she is going to be doing the presentation. So let me go ahead and start this. And then, all right, so take it over.
All right, just switch over. Hi, everyone. Thank you so much for joining. Like she said, my name is Cady Schleeper, and I'm one of the PGY1 pharmacy residents at St. John's Hospital. My mentor for this presentation is Tiffany Gonzalez. She's one of our clinical cardiology pharmacists that also works at St. John's. So I'm very grateful for her help reviewing and putting together this presentation for you all today. Of note, neither myself nor Tiffany have really any financial relationships to disclose at this time. Throughout this presentation, I will be utilizing several abbreviations, so they're listed on the screen here for your reference. If you'd like to take a moment to take a picture of it, you're more than welcome to. But my hope is at the end of this presentation, you guys will be able to correctly identify patients who have true statin intolerance. You'll be able to recall the LDL goals for the various statin benefit groups, and that you'll be able to choose an appropriate alternative for patients who aren't able to tolerate those statins. So to start off, I wanted to quickly review the 2018 blood cholesterol guidelines. So if you recall, the statin benefit groups, there are 4 of them. We start off with our secondary prevention in our patients who've experienced a clinical ASCVD event, so things like our heart attacks or strokes. The other group, or rather this group, their LDL goal per these guidelines is an LDL of less than 70 milligrams per deciliter. The next group that we often talk about are patients with severe hypercholesterolemia or an LDL greater than 190 milligrams per deciliter at baseline. So for these patients, we want to lower their LDL to at least less than 100 milligrams per deciliter. Another primary prevention group that we often talk about are patients with diabetes. They're usually indicated for a moderate intensity statin if they're older than the age of 40. This group doesn't really have a set goal per se. They just want to see more of a 50% reduction in LDL per these guidelines. And then our last group is our patients with an elevated 10-year ASCVD risk. So based on that calculation, patients with an intermediate risk will want to have more than a 30% LDL reduction, where our patients with a high risk or a score of greater than 20%, we want to lower their LDL by at least half. In terms of medications that these guidelines recommend, for our clinical ASCVD patients, they will be indicated for a high-intensity statin as a first-line agent. If they're greater than 75 years old when they have a clinical ASCVD event that would indicate them for a statin, we can start them off at a moderate-intensity statin. If they're already on a high-intensity statin before this event, it's appropriate to continue their high intensity, but at this age range, it's more up to the clinician's discretion. For second-line agents, we usually consider adding ezetimibe, and then for third-line agents, we can add our PCSK9 inhibitors. For our severe hypercholesterolemia group, or those with a baseline LDL greater than 190, we also would want to start them with a high-intensity statin. And then we would want to add an additional agent of ezetimibe or a bile acid sequestrant or PCSK9 inhibitor as our third-line agent for patients who are not meeting that LDL goal of less than 100. For our patients with diabetes, we want to start them off with a moderate intensity statin. If they're still not seeing that reduction of 50% that we were wanting to see, we can consider increasing the intensity of their statin as a second-line agent, and then consider adding ezetimibe on if they're still not meeting their LDL goal. And then our last group, depending on their risk, we can choose to start a high-intensity statin or a moderate-intensity statin. Our high-intensity statins are indicated if they have that elevated LDL risk or ASCVD risk score of greater than 20%. Our moderate-intensity statins are indicated if they fall in the borderline or intermediate risk score. For all of our patients, if they are not meeting a goal, we want to increase their statin intensity to a high intensity statin if they're not already taking one. And then we can consider adding ezetimibe or a bile acid sequestrant as a third line agent in these patients. On me?
Maybe just click on this.
There we go. But the main takeaway is that statins are considered first line for all 4 groups. Oh, did somebody comment something?
Yeah, I was just making sure everybody could hear you. Sorry.
Okay, no, I thought maybe they were saying that they couldn't hear me and I got scared. No, that's okay. So in terms of our statin dosing, we really only have 2 agents that qualify for a high intensity, and that's our atorvastatin and rosuvastatin. The high intensity dosing for atorvastatin falls between 40 and 80 milligrams per day, whereas rosuvastatin is 20 to 40 milligrams daily. And studies have shown that they can have at least a 50% LDL reduction with these doses. Moving into our moderate intensity statins, that's still our atorvastatin and rosuvastatin, but we can also see benefit from simvastatin, pravastatin, lovastatin, and pitavastatin, fluvastatin. And then our low intensity statins are simvastatin, lovastatin, fluvastatin. They are usually reserved for patients who don't tolerate very high doses. So this is more here for your reference for later if you would like to use this as a resource. Let's see here. So now I want to briefly review how cholesterol is made in our liver. So you guys are probably familiar with this mevalonate pathway, but essentially what happens is there's a series of enzymes that cascade to create cholesterol, and then it is then packaged as VLDL and released into the bloodstream. As it's metabolized throughout the body, it gets the triglycerides leave and we get LDL formation. Sorry, skipping ahead. So when we have our statins, they come in and they bind to this enzyme HMG-CoA reductase and prohibit the cascade from completing. And so as a result, we tend to see less LDL production. And with the reduction of cholesterol, we also get an uptick of the SREBP, which in turn increases our LDL receptors, which will further lower our LDL cholesterol by bringing that into our hepatocytes. And as a result, our liver becomes happy. So now moving into what our statin intolerant patients look like. So statins are associated with some side effects. There is some evidence to suggest that patients are more likely to develop diabetes, though most of this evidence has shown that the risk of developing diabetes is much less than the rate of ASCVD events that we see. So the benefit would be to still add it. And then there's not a clear, excuse me, lost my train of thought. There's not a clear cause of how statins cause the type 2 diabetes. It's thought that could be due to the changes in body weight, as well as some of the, so sorry, just completely lost my train of thought.
It's contagious.
It is, it must be this chair.
I think it is.
Main takeaway is that we're not entirely sure of what the mechanism is for the type 2 diabetes development, but patients are more likely to benefit from being put on a statin than to experience the type 2 diabetes. There are also some concerns for neurological conditions, though patients, wow, oh my goodness. So for neurologic conditions, there is some concern that it may increase the risk of developing like Alzheimer's. But again, the evidence behind that is not super strong. And then for hepatotoxicity, there is some studies that have shown that patients are more likely to develop AKIs when they first start their statins. But there's also evidence suggesting that there's no long-term kidney damage or chronic kidney damage that results from statin use. And then for our hepatotoxicity, we're all aware that we need to monitor our LFTs when patients are on statins. But probably the most common side effect that we see with statins is our muscle symptoms. And so these muscle symptoms affect both our large proximal muscle groups, and it will occur bilaterally. And so the most common one that we will see is actually our pectoral muscles. We can also see myalgias develop in our quadriceps, our biceps, and our deltoids. And this is the most encountered side effect, and it affects roughly 5 to 20% of patients. However, the rate of statin-associated muscle symptoms in randomized controlled trials was actually very low. It occurred in less than 5% of patients. And so one of the studies that brought this to light was the Samson trial, which was a multiple crossover 3-arm double-blinded placebo-controlled study. There was 49 patients included in this population who had previously tried statin therapy and were not able to tolerate it. And so these patients were given 4 bottles of they were all given 4 bottles of atorvastatin, 4 bottles of placebo, and 4 empty bottles. And they submitted a daily symptom score rating their intensity from 0 to 100, and they were able to stop the medication whenever their symptoms became intolerable for the month, and then they would restart the next bottle the next month. They still reported symptom scores even if they stopped taking the medication to track their symptom resolvement. And what the study had found was that the occurrence of the mean score, rather, for patients who were on the placebo pills were an 8, whereas statins, they reported a mean score of 16.3 and then 15.4 in placebo. So there was really no significant difference between patients who were taking the statin and the placebo. And then in another study, the ASCOT LLA was a randomized double-blind study, and they found that patients who were given statins and placebo and were blinded had no significant difference between the rate of muscle side effects that presented, but whenever it was unblinded and the patients were aware of which medication they were taking, they did have significantly more side effects with the statin than the placebo. And so this has led researchers to conclude that there's really a nocebo effect where just the act of taking a pill causes patients to think they have muscle symptoms and they're more aware of it. And so patients who are more likely to develop muscle symptoms include women, patients of Asian descent, and our elderly population. So what do we do for patients who develop these symptoms? Well, first we want to rule out any other causes of the muscle symptoms. So this could be our hypothyroidism, our vitamin D deficiency, recent exercise, or even their occupation, like if they were a mailman and are doing a lot of walking. We also want to screen for drug-drug interactions. So some of the more common medications that can increase the concentration of statins include our glucocorticoids, our antipsychotics, some of our HIV medications, as well as our azoles, macrolides, and other immunosuppressives, and then some calcium channel blockers and gemfibrozole is also a concern. Once we've ruled out those causes, we want to stop the statin until their symptoms resolve. Then we can do one of 2 options. We can choose to re-challenge their statin at a lower approved dose or even an alternating dose strategy. It should be important to note that the FDA has not approved an alternating dose strategy and they really haven't been studied in our randomized controlled trials, but you can choose to give 40 milligrams of atorvastatin one day followed by 20 milligrams the next day and alternate. Or you can just dose every other day. The other option would be to switch the statin completely to a new agent and try to pick an agent that has a different lipophilicity. The reason why I chose to list the rechallenge of statin before the new statin is mostly because patients already have access to that medication and they don't have to purchase a new medication on top of it, so it's a little bit more cost effective. But some patients may choose to not re-challenge their statin. They may have decided that that's not going to work for them, and so would prefer to switch to a new statin. I've also included for your reference the hydrophobic statins and our lipophilic statins for your reference. It's important to note that there is a high intensity statin listed in each group. And it's actually thought that the lipophilic statins are more likely to diffuse into our extrahepatic tissues and have more muscle penetration and are at a higher risk of statin-associated muscle symptoms. However, this has not really been proven in our studies when comparing the hydrophobic to our lipophilic. So I do have an active learning question for you all. MA is a 49-year-old accountant who was recently diagnosed with diabetes. He was started on atorvastatin 20 milligrams daily at his last office visit 2 weeks ago, but today he calls the office complaining of new muscle cramping in both legs. He's been working overtime, so he hasn't been able to go to the gym very much in the last month. Would MA be considered a statin intolerant?
I can tell you what I would do in that situation.
Okay, what would you do?
I would probably just have him stop it for a few weeks and see if it gets better. And if it does, we could try it at like 10 milligrams.
Yeah.
But I wouldn't necessarily consider him statin intolerant with just one.
Exactly, because he's only tried the one statin. He's not truly statin intolerant. And so my next question was going to be, what advice do you give MA? No, that's perfect. So like you discussed, not going to show the answer here, but that's all right. Stopping the atorvastatin would be an appropriate option, and then rechecking in with the patient in a few days would be appropriate. Some patients, it might be beneficial to go ahead and call in another prescription for a different statin, have them start taking that once their symptoms resolve. But we wouldn't want to add statins as like an allergy to their chart at this point because they might be able to tolerate other statins. So now I want to spend a few minutes talking about the 2022 expert consensus guidelines that were released. So these guidelines also still have our 4 statin benefit groups, but it's important to note that they separate our ASCVD group into patients at very high risk and then our patients who are not at very high risk. So just as a refresher, our clinical ASCVD patients are patients that have experienced a CABG or revascularization, have peripheral arterial disease, experienced a stroke or TIA, or have angina or myocardial infarction. And so what classifies them as being very high risk is having multiple major events, so that MI, stroke, or symptomatic PAD, or ACS in the last 12 months. Another way that they can qualify as being a very high risk would be if they had a major event and then also have multiple risk factors. So things like diabetes, chronic kidney disease, heart failure, or are older in age, have a genetic component to their elevated LDL by having heterozygous familial hypercholesteremia is also a possible reason for them to have be considered very high risk. Another risk factor that I'd like to point out is having an LDL that's greater than 100 milligrams per deciliter, even though they are currently on a statin and ezetimibe. But the important difference between the blood glucose guidelines and then this expert consensus is that they've actually reduced the LDL goal for our very high risk patients to less than 55 milligrams per deciliter. And the reason why they adjusted that LDL goal is based on 2 trials. One is the Improve It trial. So this trial specifically looked at patients with acute coronary syndrome that had an event in the last 10 days. And they compared simvastatin alone to simvastatin with ezetimibe. And these patients had an average LDL reduction not a reduction, but an average LDL cholesterol of 53.7 in the group that had both the simvastatin and ezetimibe compared to the 69.5 milligrams per deciliter in the group that just had simvastatin. And what they found was that the group that had the combination therapy experienced significantly less events such as CV death, non-fatal MI, unstable angina, and coronary revascularization and stroke. The other trial is the 4-year trial, and this study looked specifically at placebo compared to evolocumab. So evolocumab is one of our PCSK9 inhibitors, and they saw that evolocumab had a 59% decrease. So they went from an LDL of 92 milligrams per deciliter to 30 milligrams per deciliter and had significantly fewer events, 9.8% compared to 11.3%. For our patients who are not at very high risk, they are patients that have only had one major event or are lacking multiple risk factors. So they are still indicated for therapy because they have that clinical ASCVD, but maybe don't need to be quite as aggressive in their LDL lowering. And so the normal goal of less than 70 would be appropriate. And so just to summarize, our very high risk patients will have the LDL goal of less than 55. Those not at very high risk will have an LDL goal of less than 70. And then for the most part, our patients who are using medication for primary prevention just need an LDL goal of less than 100 milligrams per deciliter, though there are certain caveats to that depending on the population. So another active learning question for you guys. HC is a 64-year-old woman who was recently hospitalized. She presents for a follow-up visit today and tells us she was diagnosed with PAD while in the hospital, and she has now started taking atorvastatin. Her past medical history just is pertinent for seasonal allergies, and today her blood pressure was 122/78. Her LDL at this visit was also 148 milligrams per deciliter, and she is a non-smoker. What statin benefit group does HC fall in?
Alyssa said prevention.
So she would actually be considered an ASCVD, not a very high risk, because symptomatic PAD is considered an ASCVD event. So if she is not at very high risk but does have ASCVD, what would her LDL cholesterol reduction goal be?
Less than 70, Alyssa said.
Correct. It would be less than 70 milligrams per deciliter. And then what would her LDL goal be if she experienced an MI in the next month or so?
Alyssa? She said less than 50, but I think she meant less than 55.
Correct. It would be the less than 55.
Yep.
So now let's talk a little bit about what these guidelines recommend in terms of therapy for patients who are truly statin intolerant and cannot tolerate statins. So we're first going to talk about our secondary prevention, and then our patients with severe hypercholesteremia also get lumped into this group because they have similar recommendations. But we will add ezetimibe and or PCSK9 monoclonal antibodies. For the LDL reduction, which we'll get into with the PCSK9 or monoclonal antibodies, they have more reductions seen compared to ezetimibe, and so those would probably be most beneficial in our patients that have a very high baseline LDL, but we want to get them down to that goal quickly. For second-line agents for these patients, we'd want to add either bempedoic acid or inclisiran. And it's important to note that inclisiran would not be given with a PCSK9 monoclonal antibody. They just have not been studied together, and there's no evidence supporting them. They're used together, as well as their mechanism of action is quite similar, which we'll get into. And then for our patients that have homozygous familial hypercholesteremia, we can consider adding evinacumab to our patients with clinical ASCVD who are at very high risk, or our patients that have an LDL greater than 190 milligrams per deciliter at baseline. And then for our patients who would qualify for statins for primary prevention, we will still use ezetimibe first, but our second-line agents are going to change, and we're going to use more of our bile acid sequestrants and then consider bempedoic acid as a third-line agent. So now going through these medications, we're going to start with ezetimibe since that is indicated first for all patient groups. So cholesterol is from our diet. When we eat our fatty foods, our bile acids will break down the lipids in those foods and form cholesterol, which then is absorbed into our bloodstream through the NPC1L1 channels. However, whenever we take our ezetimibe, ezetimibe, it will come in and block those channels, so we are not able to have our cholesterol absorption. So ezetimibe is considered a 2-azetidienone drug class. It's the only agent in its class. And it's contraindicated in patients who have an active hepatic disease, an elevated LFTs, or are pregnant or breastfeeding. They can also cause elevated LFTs in less than 1% of our patients, and can also lead to atheralgia development in about 3% of our patients. It's indicated for patients who are using it for ASCVD prevention, primary hyperlipidemia, and homozygous familial hypercholesterolemia, and it's dosed at 10 milligrams by mouth daily. Some of the evidence for using this comes from our SHARP trial. This was a double-blinded randomized controlled trial where patients with a no known history of heart attacks or coronary revascularization were given either simvastatin with ezetimibe or given placebo, and they found that there was an average difference of 0.85 millimoles per liter in their LDL cholesterol, and significantly fewer clinical ASCVD events, death, and it was 11.3 in our ezetimibe group compared to 13.4% in our placebo. So some pearls to keep in mind: ezetimibe is the generic option. It should be covered by most insurance companies, and it's billed to the pharmacy insurance. And then while patients are on this therapy, we would want to continue to monitor their LFTs. The next class I want to talk about is our PCSK9 monoclonal antibodies. So PCSK9, if you recall, is made in our ribosome, or in our hepatic cells. The mRNA is packaged by the ribosomes and then released into our cells, which will then bind our LDL receptors and cause the breakdown of those receptors, which prohibits us from intaking our LDL. So over time, our LDL cholesterol rises, but when we take a monoclonal antibody, it will actually bind to the preformed PCSK9 and make it to where they will no longer bind to our receptors. And so we don't have that breakdown, and our LDL cholesterol is able to be brought into our hepatocytes. This is the two agents that are in this drug class are evolocumab and alirocumab, and they are contraindicated for patients who have developed a hypersensitivity reaction to one of these two agents. There is cross-reactivity, so if they do develop an allergic reaction to one, we cannot use it in our other patient, or cannot use the other agent for these patients. Evolocumab is associated with headaches and nasopharyngitis, whereas alirocumab has been shown to have injection site reactions. The dosing for these agents depends on its indication. So for both agents, they have ASCVD prevention or primary hyperlipidemia. We want to use 140 milligrams sub-Q every 2 weeks of evolocumab. We can do a monthly dosing of 420 milligrams sub-Q. For alirocumab, we want to do 75 milligrams subcutaneously every 2 weeks. And this can over time be increased to 150 milligrams every 2 weeks. Or we can choose to do a 1 monthly dose of 300 milligrams. For patients who have homozygous familial hypercholesterolemia, I've included the dosing here for your reference. However, to be diagnosed with homozygous familial hypercholesterolemia, it requires a genetic test that we often don't see in our clinics, and it's usually done in more of a lipid specialty center. So one of the trials that I wanted to talk about was the Odyssey outcomes trial. So this one focused on alirocumab, and they compared it to placebo and found that there was an LDL reduction of 38 milligrams per deciliter after 4 months of therapy, 42 milligrams per deciliter at 12 months, and then 38 milligrams per deciliter at 2 years. And that there was a significant reduction in the amount of CV deaths as well as our clinical ASCVD events. So things to keep in mind with evolocumab and alirocumab. These are both branded products, so they are going to be a little bit more expensive, and not all insurance companies are going to cover both agents. They may pick one or the other. It is still billed to their pharmacy benefits. They also used to be referred to as PCSK9 inhibitors, But this has they're no longer referred to as this because that is now what inclisiran is referred to, and it's considered a separate drug class. And it's important to note that patients can self-administer these injections. It is a little bit more expensive, between $295 and $330 per mil, and they are packaged as 1 milliliter prefilled syringes. The next drug class I want to talk about is bempedoic acid. So bempedoic acid works within the same cascade as our statin therapy, but it's going to work at the ACL enzyme upstream from the HMG-CoA reductase. So as a result, we will see we'll see that breakdown occur sooner in the cascade, but we will still see the same end result of a reduction of LDL cholesterol and an increase in SREBP, which in turn increases our LDL receptors. And again, we have our happy liver now that we have less LDL cholesterol. So these are considered adenosine triphosphate citrate lyase inhibitors, or ACL inhibitors. There are currently no contraindications for bempedoic acid at this time, but it's important to note that they do have an increased risk of gout and hyperuricemia of about 26%. So this is something that I would counsel patients on whenever we're starting them on this therapy. It's indicated just for ASCVD prevention as well as heterozygous familial hypercholesterolemia, and it's dosed at 180 milligrams by mouth daily. And this dosing comes from our CLEAR Outcomes trial, where they compared bempedoic acid to placebo and found a difference of 29.2 milligrams per deciliter of LDL reduction. They also found a significant reduction in CV death and ASCVD events. There was also the CLEAR Tranquility trial, which looked at specifically patients who do not tolerate statins and had a baseline LDL greater than 100 milligrams per deciliter. These patients were given 4 weeks of ezetimibe and then were either given placebo in addition to the ezetimibe or bempedoic acid in addition to ezetimibe, and they found that there was 28.5% more LDL reduction than the placebo group. So this one is also a generic product, and it's billed to pharmacy insurance. And it is available as a combination product with ezetimibe to make it easier for compliance for our patients. It's a prodrug that's activated in the liver, and it is important that we are monitoring our uric acid levels since there is such a high occurrence of gout with this agent. The next group is our inclisiran. So this still works on our PCSK9 pathway, but instead of working on the actual formed PCSK9, it's going to work on the mRNA for PCSK9 and inhibit it from being packaged by the ribosome. So as a result, we don't have as much PCSK9 floating around, and so we don't see that receptor reduction. This is considered a PCSK9 inhibitor as a drug class and is now the only agent in that class. It's contraindicated in our pregnant patients, and patients have reported injection site reactions, arthralgia, and antibody development. It's dosed 284 milligrams on day 0, and then another dose is given 3 months later, and then it's dosed every 6 months following that, primarily for ASCVD prevention, though it can also be used to treat homozygous familial hypercholesterolemia. So the Orion 10 and Orion 11 trials are really what have shown the benefit of giving inclisiran. So they specifically looked at patients who have experienced an ASCVD event or were at high risk of developing an ASCVD event, and they were given patients either the inclisiran at that dosing schedule of 0, 3, and then every 6 months, or were given placebo. And what they found in Orion 10 was a mean reduction of LDL cholesterol of 104.7 milligrams per deciliter, which ended up being about a 52.3% reduction. And that was also repeated in Orion 11 with a 49.9% LDL reduction. Currently, we don't have morbidity and mortality data. That's pending in ongoing studies in Orion 4 and Victor Orion 2P. And as I mentioned previously, these agents have not been studied in head-to-head trials with PCSK9 monoclonal antibodies. So we don't know what the benefits or risks would be to be giving patients in both giving patients both agents. Also, with inclisiran working before the PCSK9 is even formed in the ribosome or by the ribosome, there may not be much benefit in giving both agents because PCSK9 will no longer have it. Monoclonal antibodies for PCSK9 will no longer have a target. So things to keep in mind with inclisiran is that it has to be administered by a clinician. It cannot be self-administered. It's also billed to the medical insurance, not the pharmacy insurance. So if you were going to give this agent, it would take some coordination with the insurance and may require prior authorizations beforehand. It's currently only available as a brand name product, but there are patient assistant copay cards available through the manufacturer. It's also quite expensive. It's $3,948 per dose. But good news is it is a pre-filled syringe at the 284 milligrams per dose, so it's not multiple syringes that would be needed. The last group that I want to talk about in depthly is our bile acid sequestrants. So back in the intestine, these medications will actually target the bile acids themselves, which prevent that breakdown or lipolysis of dietary cholesterol, so we don't have as much cholesterol to absorb. They are contraindicated depending on, the contraindications depend on which agent is given. For cholestyramine, if the patient has complete biliary obstruction, we would not want to give this agent. For cholestyramine, we want to avoid it in patients with bowel obstructions or have a baseline triglyceride greater than 500 milligrams per deciliter, or who have experienced hypertriglyceridemia-induced pancreatitis. And then for our cholesterol, if patients have developed hypersensitivity. Across all agents, though, the most reported side effect is constipation. So the dosing for primary hyperlipidemia is only available for cholestyramine and cholesterol. Cholestyramine is given at 4 grams by mouth daily or can be given 4 grams twice a day. Cholesterol depends on if it's a tablet or a granule. Tablets are 2 grams by mouth daily or twice a day, where granules are given at 5 grams daily for a week, and then can be increased to 5 grams twice a day. For our primary hyperlipidemia patients who also have diabetes, we can give cholestyramine at 3.75 grams by mouth daily or increase that to twice daily. And for time, I've only included one study on this drug class, specifically looking at cholestyramine. And so these patients were given either cholestyramine or placebo, and they looked at LDL reduction after about 7.5 years. And they found that there was a 20.3% reduction with cholestyramine compared to 12.6%, or rather it was 12.6% more than the placebo group. And they also saw that there was significantly fewer events of coronary heart disease, death, or non-fatal MI. Now this study is much older. This one's from 1984, but this was one of the first studies that I found of this drug class showing the benefit of giving this medication in LDL cholesterol. So things to keep in mind with this medication class, all these agents are available as generic products, and they are billed to our pharmacy insurance. And we want to continue to monitor vitamin D levels while they're on these agents, and they may require some vitamin D supplementation. Another thing to note was just with their mechanism of action inhibiting absorption in the intestines, there may be more drug interactions with these agents. So making sure that we're separating these medications from other oral medications is important. I also included evinacumab for completeness sake, but I won't go through these in as much detail. So this medication class binds to ANGPTL3 and increases the lipoprotein and endothelial lipase. It's also the only agent in that drug class, and they are ANGPTL3 inhibitors, and they're currently contraindicated in our pregnant patients. Its only indication, though, is for homozygous familial hypercholesterolemia. So most of these patients who are started on this medication will be managed by a lipid specialist. And then our last medication that I have also included is lomitapide. So lomitapide is also indicated only for our familial hypercholesteremia, but it binds and inhibits our microsomal triglyceride transfer protein, which prevents the assembly of the ApoB. It is a MTP inhibitor, and it's also contraindicated in pregnancy. So I have another active learning question for you all. CS is a 52-year-old woman who has tried and failed 3 statins. She had a myocardial infarction 3 months ago and is presenting today for a follow-up visit. Her medications include carvedilol, aspirin, clopidogrel, and ezetimibe. Today, her LDL cholesterol is 163 milligrams per deciliter. What medication would be appropriate to add at this time?
I want to call them PCSK9 inhibitors because I had no idea the name changed, but it's the PCSK9 monoclonal antibody.
Correct. We could add alirocumab or evolocumab, and that name change is very frustrating because I also this whole presentation wanted to say inhibitors. I'm like,
yeah,
nope, they're monoclonal antibodies. So when she returns to the clinic 12 weeks later for a cholesterol check, her LDL is 174 milligrams per deciliter. She informs you that she only took 1 dose of the medication because she was too scared to give herself the injection. She didn't think it would be a problem though because she's never had any issues receiving vaccines in the past. So what medication would you recommend instead of the PCSK9 monoclonal antibody, not inhibitor?
Alyssa answered the last question. She said the bile acid sequestrant.
So a bile acid sequestrant would be an option.
I was going to say the inclisiran.
Yes, so the answer I was looking for, which it's not going to pop up on here, was actually inclisiran, just because it is higher above in the pathway than the bile acid sequestrants. Since we're taking her off the PCSK9 inhibitor, we would be able to give the inclisiran, and it's dosed less frequently, so she wouldn't be having to get frequent injections, and it's also something that the clinician would have to administer, so she wouldn't be giving it herself.
And the bile acid sequestrants, they only have like a 20% reduction, whereas the PCSK9 monoclonal antibodies have like a 50% reduction. So
exactly,
especially with her LDL being 174, that's pretty severely elevated. So we probably need to go with the most aggressive treatment.
Exactly. Yep. So that was all I have for you guys today. So just to summarize, our patients with true statin intolerance are less common than what we probably think they are, just because patients do tend to report that muscle symptoms, but that's mostly or may be due to a nocebo effect rather than a true statin cause. We also want to make sure that our LDL goals for our high-risk patients are less than 55 milligrams per deciliter instead of 70 because the evidence from our Foreigner and our Improve-It trials have shown better clinical event prevention. And then ezetimibe is our first-line agent of choice for these patients, but for patients who have higher LDL at baseline, we might want to consider adding a PCSK9 to start with. But if they're still not meeting goal, we do have other options for them to add on.
There were a couple of questions that Alyssa asked. She said, can the bile acid be given with Repatha or Praluent or the
antibodies?
PCSK9 monoclonal antibodies?
They could be given together. There's no evidence suggesting that there's no like interactions between the two mechanistically. And if the patient's not reaching their LDL goal, adding a bile acid, it was the bile acid sequestrant, correct? Yes. That would help lower their cholesterol in a different way rather than the cholesterol that's being produced by the liver, but it would help lower the dietary cholesterol.
And Alyssa, I think we answered your question with the PCSK9 monoclonal antibodies. That's what the Repatha and Praluent, otherwise known as evolocumab and alirocumab. That's what they're called now. And the inclisiran is the PCSK9 inhibitor.
Correct.
Very confusing.
Yes.
Mind if I make a comment?
Yep.
Okay. Hi everyone, this is Tiffany. I am Cady's mentor. I just wanted to make an additional comment about the bile acid sequestrant. So as Cady said, I don't think there's necessarily a drug interaction between the two, that you couldn't use them together, but I think that per the evidence, it may take a while to get to that combination. So I probably would recommend the bempedoic acid prior to the bile acid sequestrant. And if the patient's tolerating all of them and using them appropriately, I don't know that you would actually get to the next level of needing the bile acid sequestrant in those more high-risk patients. I did want to make a couple other comments throughout the presentation. I applaud Cady, and I think she did wonderful. I'm very proud of her. Talking about the bempedoic acid, though, on this slide, I think we did say in the presentation it's available generically. I don't believe that's accurate. I think it's only branded. So we'll look into that and get that corrected for you guys. In addition to this last slide that we kind of talked about, the alirocumab and the evolocumab are both now referred to as a PCSK9 monoclonal antibody. So we'll correct this last question so that there's a little bit less confusion. So apologies for those couple of typos. But I also did want to kind of hone in on maybe a concept that we kind of glazed over. On slide 26, it says the 2022 expert consensus guideline. I do want to kind of add a little bit to this. It's actually an expert consensus document. Cady and I kind of anecdotally call it a guideline when talking, but if you look at the terminology, it is a consensus document. So it does have less, I want to say, backing than a typical guideline does. It doesn't have the classifications and coding of evidence, and typically these little expert consensus documents are things that are put out exactly as it says, just to kind of give some expert advice on maybe some changes that have come out since the last guideline, and likely will be incorporated into the next lipid guidelines. So in particular, since 2018, the bempedoic acid was approved, the inclisiran and the evinacumab medication. So kind of the purpose of the expert consensus document was to incorporate those in addition to the ezetimibe that had previously been mentioned and the previously known PCSK9 inhibitors. So I think that's all I wanted to add, but we're happy to answer any questions either today or in the future. We'll get a few things corrected for you guys and sent out as soon as possible.
And I just wanted to make one comment. I was trying to like clarify on my, I went to a Mayo Clinic conference, and I believe that ezetimibe and the PCSK9 monoclonal antibodies are both 2B recommendations, I think. I feel like I'm pretty sure. But based on like the ACC guidelines, we can prescribe ezetimibe or the PCSK9 monoclonal antibodies.
Yes, you can. So the 2018 guidelines put a little more emphasis on the ezetimibe than the monoclonal antibodies because the cost at that time was so significant that in layman's terms, it wasn't outweighing the benefit that the patients would receive from them. But as time has gone on, they've become more cost efficient and have shown that they have, more LDL lowering abilities and do still have those CV outcomes. So I think in terms of where the patient is from an affordability perspective, kind of ezetimibe is an easy go-to agent there. But if you have to factor in insurance and healthcare cost, it's kind of an either or.
I will say, just in like my own clinical practice, the PCSK9 monoclonal antibodies, the patient assistance programs are very generous. Like I would say 95 to 98% of my patients qualify for patient assistance and are able to get it if their insurance doesn't cover it.
Oh, okay.
I haven't had as much experience with inclisiran. The only one, I mean, I've probably prescribed it less than 10 times so far, but the only one that I've had like flat out denied is somebody with Medicare, Medicaid.
Okay.
So Medicaid is the one, I think I've talked to the reps and they said that Medicaid is not paying for it currently, or a combo of Medicare, Medicaid. So just for, reference, and there again, the outcomes data is not there for inclisiran yet.
Yeah.
No.
I'm sure it will be eventually. That's all pending, but it is very good at lowering LDL. So that much is true, for sure. Any questions from anybody online? Let me look here. Alyssa said, I was just thinking of a specific patient I have who is not following diet advice and is maxed out on one of the PCSK9 monoclonal antibodies. When she is diet compliant, it is better, but thought because the bile acid sequestrant works on like the cholesterol absorption. Yeah. That's a good thought.
Yeah.
That's for sure.
Yeah. One other thing I did want to add too is the CV outcomes are, I think it's only available actually with cholestyramine. So if you have to choose one in the group, as Cady presented in the presentation, it has the CV outcomes in that trial. But I personally would lean towards that one if possible. But they're challenging because they do have a lot of like absorption interactions with other medications.
No.
So I would hate to kind of like rob Peter to pay Paul,
Right.
if they're not going to get as much benefit. I don't know if affordability would allow them to try the bempedoic acid. I know it doesn't necessarily work right in the intestine, but it is going to have hopefully the same or similar results as we would see in some of the studies.
Alyssa, is she on a statin or ezetimibe as well? Because those, I mean, you could add those. Those would be definite options.
Mm-hmm.
Statin intolerant, and she is on Zetia. Okay. So you're trying everything, basically.
Yeah. Yeah. I mean,
okay.
I don't think there's harm. I would check with interactions of her other medications. Yeah. But, and I don't know if compliance is an issue. I'm not sure.
Sure. Yeah, I wonder if maybe she's not taking every dose like she's supposed to. She might be a good case for the inclisiran just for
the compliance
portion of it, because you have to go to the facility to have it done, and they're like, they schedule that, it's tracked and all of that.
And it's every 6 months after you get your initial 2 doses. So
right, so it's infrequent. Yeah. You said not with medication, Alyssa. What do you mean? She doesn't have a microphone, so she has to type everything.
I understand that's often me, and it's timely.
Oh, she said she is compliant with the medication.
Oh, okay.
So, okay. Well, we might be doing the best we can for her at the moment, unless the physician wants to try and add something else, which may require more monitoring and may cause more side effects or other medication absorption issues. So. Okay, any other questions? Okay.
All right. Well, thank you guys.